Good evening. I'm Bill Brown at Brookings Mountain West, so welcome and thank you all for coming, whether it was by choice or not. We're thrilled to have you here. And we're especially pleased to have our colleague Ross Hammond back. Ross is going to talk about the challenge of obesity tonight, and I'm going to leave him to elaborate on what he means by a systems approach to that, but you're in for an entertaining lecture. Ross directs the Center on Social Dynamics and Policy at Brookings Institution, where he's also a senior fellow in economic studies, and we've caught him on his global travels dealing with this issue. But he's going to talk about this issue and also give us some information specific to Nevada. So we'll see where Nevada is on this troubling health issue. Ross is making his second visit out here to us. Some of you may have already had a chance to hear him in one of your classes. He's collaborating with UNL faculty on research and grant projects, so we couldn't be happier to welcome him back. And I want to try and get us started on time and reward everybody who shows up on time for lectures. So Ross, please.
Thank you very much, Bill, and thank you all for coming, whether it was voluntary or not. And I'm thrilled to be here and to be talking to you about this important issue, which is something I'm working on quite a bit at the moment, including a lot of work with some faculty members here at UNLV. I assume that you're a pretty diverse set of backgrounds in the audience. Some of you may know a lot about this issue, and some of you may know very little about it. So I'm going to start by giving you a sense of the scope of this problem, the context in which it's occurring, why we care about obesity, the impact it has on public health and on economics. And then we'll talk a bit about what is behind this epidemic, why it's a challenge to address from a policy perspective, and why it's a challenge to study if you're a scientist. And then I will talk about the way forward as I see it, what I'm going to call a systems approach, which I'll define in a bit, and some uses of computational tools to help us make progress on this problem. And I'll conclude with some time for question and answers from you. Okay, so start thinking of those questions. Okay, so to begin with, this is, if you don't know already, a US and increasingly a global public health crisis, really, that we're facing. The percentage of obese Americans has more than doubled since 1970. 2/3 of American adults are now overweight, so the vast majority of Americans, and 1 in 3 are obese. Okay, so these are very large numbers. If you like graphics, this is a chart showing in the blue line the percent of Americans who are overweight, and the black line, the percent of Americans who are obese, which is extremely, even more overweight. And you'll see on the x-axis the years from starting in 1960 going through 2006. So you can see this increase over time. If you like distributions better, for those of you who are statisticians in the audience, what you're looking at here is something called BMI, the body mass index, which is used as a rough guide to obesity and overweight. And the formal definition of overweight is a BMI of larger than 25. And BMI of larger than 30 is defined as obesity. And so what you can see is the shift in this distribution toward the right, the heavier end of the BMI distribution over time. We can also subdivide obesity in the US in 3 categories. There's overweight, which I talked about, obesity, and then extreme obesity. And you'll see that over time, the overweight proportion of Americans who are overweight but not obese has stayed constant or even fallen a little bit, but the proportion of Americans who are obese has grown enormously. Okay, this is a nationwide trend in the United States. In 1989, every single state in the United States had an obesity rate less than 15%. And in 2010, there was no state that had an obesity rate of less than 20%. And the only state that was even close to the 20% mark was Colorado, which had an obesity rate of 21%. So if you like graphs again, here are some maps of the United States colored by how much obesity is present in these states. Blue, light blue is 10%, less than 10%, 10 to 14%, 15 to 19, and then as we get into yellow and red, it's more and more obesity. And you can see the changing picture between just 1990 and 2010, quite a bit changed, okay? Now, if you're wondering, where does Nevada fit in to this overall trend? In 2012, so last year, the obesity rate here in the state of Nevada was 26%. and an overall overweight rate of 62%. So 62% of the residents of the adult residents of Nevada were overweight in 2012. This is actually low for the United States, shockingly. It's the 7th lowest state in the United States. But it's important to note that these numbers doubled here in Nevada in the last 15 years. So you're behind, but you're catching up. And even more troubling, between children ages 2 and 5, the percent that were overweight here in Nevada in 2012 is 29%. So almost 1 in 3 children in this age range were overweight, and that's above the national average. So your adult rate is below the national average, but your child rate is above the national average, which doesn't bode well for the future unless something is done. So even though there's, I think it's very safe to say that this is a national problem, there are substantial disparities that are underlying these averages that I showed you, and I'd like to talk about some of those for a second. The first kind of disparity is geographic. So I showed you these state pictures, but within a state, there's quite a bit of variation usually in the United States. So here's a map, the same map colored now by county, and you'll see how much variation there is within states at the county level. If you're interested in Nevada, which you might be since you live here, here are the counties of Nevada, colored by how much obesity is present. And within this county here, I've separately calculated for you the actual obesity rate of just the Las Vegas metro area, and it's 23%, which is below the national average by quite a bit. Interestingly, even though your obesity rate here in this county is below the national average, fast food density is very high here in Nevada, in this part of Nevada, you can see. And not too many people get a lot of physical activity here in Clark County, despite the fact that your obesity rate is still quite low, although maybe that's changing. It might also suggest that the environment plays a little bit less of a role in determining obesity in Clark County than, at least to date, than it does somewhere in other places. But if you're interested, you can see the variation across Nevada in physical activity rates. There's also important disparities by gender, race, and income, and cross distributions of those things. So this is a little bit of a messy plot, but it separates men and women by race and income level and shows you how much obesity is going on in these many different subcategories. It's a lot to take in the short time I'm going to leave it on the screen. So I'll summarize for you. Among non-Hispanic, Black, and Mexican American men, higher income is correlated with higher obesity. But among women, higher income is correlated the other way. Higher income are less likely to be obese, even though most obese women are not low income. There is no significant link between obesity and education among men, but among women there is. So those are some important disparities to know about. This is also a major epidemic in children here in the United States. 1 in every 3 children born in the US today is likely to develop diabetes in their lifetime now. That's how serious this problem has gotten. You can see incredibly rapid growth in, these are 3 different age categories, 2 to 5, 6 to 11, and 12 to 19 here in the United States between 1963 and 2008. So you can see that going up and up and up. That has led to a state where about 1 in 3 school-age children here in the United States are overweight or obese. That's a tripling since 1980. And the reason why this is particularly troubling is because we know that once obesity exists, there are lots of entrenched both behaviors and quite tenacious physiological processes that resist weight loss. And the majority of obese children then become obese adults. So a lot of obesity, a growing amount of obesity in our children means there'll be more obese adults in the future. We're also not alone. If you take a slightly broader perspective, you'll find that obesity is actually a global problem now. About 2 billion people are overweight and obese in the world now, globally, which is about the same number of people who are nutrient deficient, who are undernourished. So we have as many overnourished people as undernourished people in the world, which certainly wasn't true a decade ago. And actually 2 out of 3 of the overweight people in the world live in developing countries. So this is very much a global problem. Here's a little illustration of that for you, for those of you, again, who like graphics. These dots that you're going to see moving on the screen here represent different countries in the world. They're color-coded by the region of the world and in which they're located, and this is men and women and BMI. And you'll see the dots, almost every single dot, moving from the lower left, low BMI for both men and women, to the upper right. They're moving at different rates, but they're all moving. So almost every country in the world has increasing obesity. And if you're curious where the US fits relative to other countries, I'll show you this movie again, and this time the one that's highlighted is the US. So you can see how it fits in to the global population. All right. So if you want to see the most current data that we have for the full world population, these are 2008 data for global obesity rates. Orange and red are lots of obesity. You'll see that except for parts of Africa and parts of Asia, there's very widespread overweight and obesity. Okay, so why do we care if there's so much obesity? What does this actually do? Well, the first thing that it does is it has a huge impact on health. There's many, many, many health conditions for which obesity puts you at much higher risk, including coronary heart disease, which is 50% more likely in the overweight, twice as likely in the obese, and 3 times as likely in the severely obese. Type 2 diabetes, which I'm sure you've heard a lot about. Obese women are twice as likely to develop type 2 diabetes as those with a healthy weight. Hypertension, blood pressure, and actually much higher risk for at least 3 or 4 kinds of cancer, for stroke, for liver disease, for arthritis, for asthma, for sleep apnea, and I could make a longer list. So here's to give you an idea of the correlation here. This is the percent obese in a county in the United States, and this is the percent that are diabetic, and you can see a very strong correlation between those two things. So I said this already, it's estimated that 1 in every 3 children born today in the US will become diabetic, and the implication of that is that life expectancy in the United States is likely to go down for the first time in 100 years because of obesity. So people will live less long, and they will live much less healthy lives. There are also some economic costs to be aware of. The economic costs associated with obesity in the US come to about $215 billion a year. And they come from at least 3 different sources. The first of these are direct healthcare costs. So medical spending in the United States is increasingly driven by obesity and the diseases to which it's related. 21% of all US healthcare costs are already attributable to obesity. That's a number that doubled in the last decade and could easily double again in the next decade. So this leads to about $150 billion in medical spending that would otherwise not be there. And actually private payers bear the majority of estimated costs and pass it along in insurance premiums, although it does show up in Medicare and Medicaid also at significant levels. There are also some indirect costs. Because of all the health problems associated with obesity, there's quite a bit of absenteeism and disability that is caused by obesity, and those are substantial numbers as well. And then finally, there are transportation and infrastructure costs associated with obesity. Moving heavier passengers around the globe and around the country takes more fuel. So airlines burn about $1 billion more fuel every year because of obesity. And on the roads, we burn about $2.5 billion worth of extra fuel every year than we used to. In addition, but I don't have numbers for them, moving more food, more waste, and larger products takes more fuel. We're having to revamp our entire healthcare infrastructure to deal with heavier patients that need larger hospital beds, larger ambulances, different weight tolerances, and increasingly the military in the US is having a tough time recruiting enough soldiers who meet the weight requirements. And so this has actually become a national security issue. Because of the increases that we see in childhood obesity, this is likely to be a substantial and growing problem in the future, even if we act now to curb increases there'll be a long half-life of the childhood obesity we already see now. To give you a sense of what this looks like from another angle, this is a little bit harder to explain. These 4 points here represent birth cohorts. So these are people in the United States who were born between 1926 and 1935, 1936, 1945, et cetera. And this is the age people who were born in this era got to be before 20% of them were obese. So people who were born between 1926 and 1935, it took them into their 50s before 20% of their peers were obese. And people born between 1966 and 1985 were only in their 20s by the time 20% of them were obese. So there's quite substantial difference. Okay, so what is going on here? What is behind all this? Well, in a way, obesity is very simple. It results from energy imbalance. If you take more energy in than you consume, you will gain weight. It's as simple as that. And also simple are the behaviors, more or less, that drive energy imbalance. There are things like eating, exercise, sleep, and stress. But the things that drive those behaviors, that affect what we eat, how much exercise we get, how much sleep we get, and how much stress we experience, are extremely complex. They involve genetics. They involve physiology and metabolism. They involve our brains and the way we think. They involve advertising and marketing. They involve the way our cities are built and we structure our communities. They involve the physical environment. They involve our food system. And there's a lot of interaction between these different things. There's a huge diversity in the set of actors who play a role in this system. We have families and schools and the food industry. We have healthcare providers. We have insurance companies. We have government agencies all playing some kind of role in this system. And there's a lot of diversity. There are many different pathways to obesity. So people who become obese do so for very different reasons. There isn't a single driving cause. So to give you a sense of what this looks like, for those of you who like pictures, here are some of the levels of scale that are involved in obesity for which there's good evidence, going all the way from the genetic to the environmental and policy levels. And this is a picture that was drawn up by a government-sponsored panel in the UK trying to identify all the factors that play a role in obesity and which ones are connected with which other ones. And you'll see, even though this is too small for you to read the labels, that pretty much everything is connected with everything else. There's enormous interaction between these different factors. And some of those factors themselves are very complex. So the environment is one that I talked about. For example, the food environment. This is a map of exposure to fast food, density of fast food restaurants in Manhattan, in the 5 boroughs of New York City, including Manhattan. And you'll see that this is actually an incredibly diverse picture. People are very much experiencing different densities of fast food depending on where they live, even block to block sometimes. Physical activity is also affected by the environment where there are opportunities to engage in recreational activity. And our social environment matters. This is a famous study published a number of years ago claiming that obesity is contagious, that it moves through social networks. So this is a picture of a social network that was studied as part of that study. And this kind of social influence plays a big role in obesity as well, and in some of the behaviors like physical activity. Going down a level of scale, neurobiology and physiology play a role. 3 quite separate and quite powerful brain systems play a role in eating. When you make a decision about what to eat, you're actually 3 different parts of your brain are working or fighting amongst themselves to try to determine what you'll actually do. And as you gain or lose weight, your body is actually changing its biology in an adaptive way to reflect that weight gain or weight loss. Actual biochemical changes are occurring constantly as you gain and lose weight. And then at a community level, there are lots of different structures that are at work. There's what's happening in our schools and our families, but also what's happening in the broader community, what kind of discourse we are engaged in, what kind of social norms there are, what kind of cultural values and beliefs we have. There's what the media is telling us, and all of these things are interacting. And then at a broader level, the system, the food system itself, actually determines what food is available to us, what that food costs, what it contains, what kind of nutrients it does or doesn't have, what kind of chemical exposure it might or might not create for us, both directly when we consume it and in our environment, in our soil, in our air, in our water. And that's a global system. We import a lot of our food, we export a lot of our food. It's very, very complex and involves all sorts of different steps and pieces. So the point of showing you all this is to drive home the idea that there is likely no single explanation for what caused the obesity epidemic, and there is likely no single solution that will just make this go away. There's no magic bullet here. There's unlikely to be any single thing we can do that will meet all circumstances, all contexts, all ages, all needs. So this is what we call policy resistance. This kind of complexity means that our intuition about what the right things to do are might be misleading, that interventions that succeed in our schools might actually just be offset by what happens when the kids go home from school. It might not be enough to solve the problem in one context. And we might actually have to think in a systemic way where we actually coordinate across multiple contexts and multiple factors. So we've made some progress in controlling this epidemic, but we're far from actually making as much progress as we'd like. And I think there's increasing recognition in people who work in this field that we can't just keep doing what we're doing. We need to actually devise some new solutions that are more integrated. We need some tools and strategies that can actually take all these many moving pieces into account and actually leverage how connected everything is rather than being defeated by it. So the Institute of Medicine recently released a fairly definitive report about obesity, which highlighted this need for multi-level and interconnected solutions. One of the tools we have at our disposal to try to do that are computational models. These models in which we actually create artificial worlds and societies in computers and use them to help us understand real ones better and how real ones are likely to react as we change the policy options available to us, are very useful for this kind of situation. They can help us anticipate where the best places to intervene might be and how to coordinate across all these different sectors of activity. And these have been used in other spheres of public health and public policy. I've been part of several different efforts that look at different kinds of public health and in which policy is based directly on these models. What I'm showing you here, just so you get a flavor of these artificial society computational models, are some models that were developed to study the flu, the spread of flu pandemics like we had in 2009 and 2010. Some models that have very detailed representations of cities. This is Los Angeles that you're looking at, downtown Los Angeles, all the buildings and roads and the people on the roads. And this is being used for evacuation planning and for management of toxins in the environment. And tobacco policy is being studied this way as well, how to control cigarette smoking. And you'll see that all of them have a lot of spatial complexity, and all of them are dynamic models in which there are individual actors doing things, and we can explore the response of those individual actors to different kinds of policies we might put into place. Okay? So I want to highlight 3 different ways these models can be used for obesity in particular, which is very new, the application of these tools to obesity. The first of them is to better understand how all these different causes of obesity are working together. And to do that, we're building models in which we take those pictures I showed you, like the food environment and social networks and the brain, and we try to link them all together so that we can look at a zoom out and look at a very big level at the environment in which people operate, the kinds of food choices available to them, what they're exposed to in the way of advertising, and we can zoom in to their social structure, what kind of social influences they're subjected to, what their social norms and cultural beliefs might be. And we can zoom in even further to understand the ways in which different brain systems and different biological systems influence the choices that people make. And we can try to coordinate across those many different levels of scale. And we have learned some things already in the early work we've done in this area. For example, we've learned just how important early childhood is in the development of obesity. What happens to you when you're very young can shape very dramatically the preferences that you have for different kinds of foods, the choices that you'll make later in your life, and even given equivalent choices, the outcomes that you'll experience later in your life can all be framed very early on by the exposures that you face as a young child. We also know how important social norms can be, how many people might actually in the United States still not realize how their weight actually fits into an objective scale rather than just among the peers that they routinely encounter. We've learned how effective policies are likely to require coordination between many different sectors, that just thinking about a health outcome like obesity from inside the healthcare system is just not going to be sufficient, that we need to think about things like education policy, housing policy, transportation policy, and our broader food system if we're really going to get a grip on this. The second way in which these models are being used is to understand what works and why things that seem to work might be working. So what we're doing with these models right now is to try to take two of the most successful obesity prevention interventions that have happened in the world, one of them in Massachusetts and one of them in Australia, and to actually understand, to tease apart what it is about them that worked. And these are both what are called whole of community interventions. And this is an approach where you actually work at the community level and you try to coordinate between schools, between households, between recreational centers, between universities, and try to create for an entire community a much healthier and more integrated environment. And when you do that, you're actually taking 12 or 13 or 14 different actions at the same time, which makes figuring out afterward what the magic combination was that actually worked very difficult. And the third and broadest lens for this is to actually understand how our environment and other disease and healthcare factors and our agri-food system interact to drive the outcome of obesity. So what are we learning so far from all this? I think we've learned just in the last 5 or 6 years some 5 very important general lessons about obesity and about what works or does not work in tackling obesity. The first of these is that we, as I've repeated several times, we need coordinated approaches. We need things that don't just happen in one context, but that happen across contexts in a coordinated way. The second is, given how hard it is to do that kind of coordination, and given how gridlocked our political system is, the community may turn out to be the right place to intervene, the right level of scale. It's increasingly communities, cities, metropolitan areas that are doing the best work in controlling obesity, not states, not counties, not the federal government. The third thing on my list is early prevention. It's so hard to reverse many of these early influences, and it's critical to start young. Prenatal through age 5 is a critical window for intervening in obesity. The fourth thing on my list is there are lots of good ideas about things we could do to address obesity, but none of them work very well unless you pay attention to implementation. It sounds like a great idea to put healthier food in our schools, but if you don't work with school principals and school cafeteria managers to make sure that it actually can happen feasibly, then that idea isn't going to help. There's lots and lots of evidence for that now. And the fifth is the power of social. We live in a social world where social norms and perceptions and marketing are very, very powerful. And right now, many of these forces are working against us as we try to tackle obesity. We need to find out more important ways to have them work for us instead. Okay, so to give you a quick sense, since I have in the last couple minutes I have of what I'm talking about, specifically when I talk about these coordinated strategies, let's think about some actual strategies, like putting nutrition labels on food, whether it's on menus or whether it's on containers of food you buy in the grocery store. So that's a good idea, but it works a whole lot better if you combine it with nutrition education in schools, so that kids actually know how to read a nutrition label in the first place. And lots of, believe it or not, lots of interventions have taken place where we just add menu labels and we don't teach people what they mean, what a calorie is or how to read them. And they just don't work very well by themselves. Similarly, investing in more parks, more recreation infrastructure to encourage people to exercise works best if you can actually remove some of the other barriers to exercise, like crime, lack of public transportation, and lack of supervision for children. So again, doing more than one thing at once across contexts. Similarly, if you make an investment in parks and you make sure that healthy food options are available near those parks, you do a lot more good than either thing can by itself. And so on and so forth. I'm not going to go through the full list of these. So I'll just conclude, because I want to allow a little bit of time for questions and a discussion, by recapping that obesity is a major challenge for this country, that it is a national challenge that affects all age groups and all demographic groups, even though there remain important disparities, that there is not a simple cause or simple solution, and that searching endlessly for one is not likely to be a fruitful use of our time. That what we instead need are coordinated strategies in which we address multiple sectors and multiple factors at the same time in a way that has a plan behind it, and that these computational policy models that we and others, including some faculty here at UNLV, are developing can help us do that. Okay, I'll stop there and take questions, and my email is here if you have questions you want to follow up later. Thank you. About 10 minutes for questions. Yes?
Have you guys thought about the outcome? Like after, say if, just magically happened, everyone's not obese anymore.
Mm-hmm.
Like, go back to the slide where you have like the doctors, and you'd be putting doctors out of jobs basically. So the doctors that specialize in like the gallbladder and the types of cancers you get for obesity, when they be getting like put out of their jobs afterwards?
Some doctors might need to change their focus, yes, but it's probably a pretty small effect compared to the massive economic and public health disaster that we're facing now. And I showed you slides about how much the world has changed just since the 80s. And we didn't have a terrible problem with unemployment of doctors in the 80s before this epidemic really took off. So I think we could go back probably to that situation. Other questions? Yeah.
I'm really interested in this idea of building up infrastructure. Do you have any ideas as far as funding, or these new?
As far as
funding.
Funding for
these integrated systems approach.
Well, I think the first thing we have to decide is what it is that we should do. And actually funding has not proven to be the issue. We're spending hundreds of millions of dollars on obesity prevention in a very uncoordinated way at the moment. So if we could repurpose the existing funding in a more intelligent and coordinated way, I think we could make a lot more progress, and we could actually probably use it much more efficiently. But there is funding usually available, and in many cases, you can actually save quite a bit of money if you're an employer or if you're a city by addressing this issue, because it costs, at the other end, it costs those same entities, the employers, the cities, huge amounts in healthcare costs to not deal with it. So, yeah.
Question, you talked about the benefits of having nutritional information that's disclosed to people.
Right.
Do you have any information on how successful, because I think the big problem is exactly what you said,
Yes.
is that people don't understand what that means. How about the effectiveness of the training or the education to children and adults even on what that means?
Right. Well, so I think I use that just as an example, one example of this idea that you need to coordinate across multiple spheres of activity. And I think there's overwhelming evidence that just putting nutrition labels by itself doesn't seem to do much. And I think there's actually two reasons for that, if we want to get into that as a topic. One of them is that a lot of people don't know how to interpret the information, and education can help partner with that intervention to make that more effective. The other is that lots of people don't pay attention to the labels, and those who pay the most attention are those who least need to be paying attention in many cases. And that part of how you solve that problem is by delving in the media, social media and awareness space and social norms about eating and about the act of eating and what it involves. So, yeah. It's hard, there's lots of hands there. How about there? Yeah.
I noticed that you didn't have any information regarding the pharmaceutical developments on trying to treat weight loss. I know it's kind of a Band-Aid on, cut. But
Right.
I think pharmaceutical sector is trying to meet this challenge of obesity and weight loss. Do you see that fitting into the solution?
I think that both pharmaceutical and very intensive counseling solutions work very well for individual people, but they're unlikely to be a population level solution that's affordable, that doesn't have terrible side effects. Most weight loss drugs that have been discovered so far are monkeying with quite complex brain chemistry that I showed you earlier, and they usually have unpleasant side effects of one kind or another. So I think if we wait around for a magic pill to solve this problem, that we'll pay a heavy price. Yeah.
Your models, what do they shine a light on? Food deserts, and has there been any follow-up? Since it's such a stark example, I would think that it would be kind of a low-hanging fruit to tackle that subject.
So this is a great example of sort of the general theme of my presentation, because people noticed that there were these food deserts. And so for those of you who haven't heard this term before, a food desert is a geospatial area, a neighborhood, in which there just aren't a lot of food options. There aren't grocery stores, there aren't fresh food vendors. And so therefore it's hard to make a healthy choice because there's nothing healthy in the neighborhood. And so people thought that this might be an obvious low-hanging fruit, and actually a lot of investment was made in particular cases of solving food deserts by introducing grocery stores and so on and so forth, and it didn't work hugely well by itself. And one of the reasons, that I think there are two reasons why it didn't work hugely well. One of them was that putting a grocery store in the neighborhood doesn't mean people will buy healthy things in the grocery store. Just because there are now apples available doesn't mean people will buy apples and stop buying soda. So it doesn't solve the problem by itself. And the second is we've learned quite a bit about where people actually buy their food, and it isn't always close to their house. Sometimes it's close to where they work. Sometimes it's another location where they're going for some other reason, with their kids, for example. And so it seems evident that if you can draw a circle around a bunch of houses and there's no grocery store in that circle, we should do something about it. But it's actually not so simple. Yeah.
In instances for like battling against fast food places and stuff like that, isn't a challenge of doing so maybe the funding from those places to try to keep their business? It's a straight up forward battle between eating good and eating bad. You know, you've got a major influence coming from those places. How would you address something like that?
Well, so I think I'll answer your question in two different ways. I mean, I think there certainly is a very important way in which there is not a level playing field for healthy and unhealthy options. Healthy options are not advertised and marketed. They cost more. They're harder to get. And so it's just not as easy to make a healthy choice for most people as it is to make an unhealthy choice. That's certainly true, and I think there's certainly a role for policy to come in to try to level that playing field in various ways. Given that, though, I think that seeing it as a battle between the food industry and public health is probably not the most productive way forward. And actually, I think it can be in the interest of the food industry to change what they're doing, and it can actually be in the interest of public health to help them change what they're doing. Because what you'll hear over and over from the food industry is that they put healthy things on the menu and no one buys them, and there's no demand for them, and they can't make money selling them. And you'll hear over and over from consumers that there are no healthy foods available or they cost too much. And so there's a chicken and egg problem here, and I think there's a way to solve this that's actually mutually beneficial.
Yeah, I think one of the latest social media thing, latest pictures I saw on Facebook, for example, of fast food wise, it's a toss-up because a cheeseburger, which is 400 calories or whatnot, is $1, whereas a salad is $4 or $5.
I'd say part of the reason for that is because of the way our food system is set up, and you have to remember that our food system was created after the Dust Bowl, when there was widespread concern that we would have a famine in the United States. We wouldn't be able to feed people enough. And so it's set up to produce cheap, plentiful calories. And now we're reaping the unfortunate side effects of its success in doing that. Other questions? Yeah.
So when you say it's like a psychological thing, if you're in the mindset of not paying so much for healthy food or not doing the things you need to do to exercise, and obesity would never be eliminated, because I mean, we have health classes, 8th grade, 9th grade, and they teach us how to calculate calories and everything. but it's basically up to the person whether they want to take the steps to losing weight or not, right? So,
But the reasons why they do or don't do that might be quite complicated, and only some of them might be under their direct control, is what I'm suggesting. Yeah.
So kind of a two-part question.
Yeah.
In terms of looking at the data and thinking of operationally defining obesity,
Uh-huh.
has it changed over time in terms of the definition?
No, it probably should have changed. So the way, so I'll say three things about that. The first is that the tool we're using for most of our population level statistics is called body mass index, BMI, and there are these defined cutoffs of 25 to 30 is overweight and above 30 is obese, and you can actually demarcate several other tiers of extreme obesity above that. And the first thing that I'll say is that actually those numbers, those cutoffs should be lower, because we know that health risks start before BMI of 25 and BMI of 30. And there's pressure to not revise them downward when they probably should be. We also know that depending on your genetic and cultural ethnic background, you may actually experience higher risk at much lower BMI. So people of South Asian descent, for example, are at much higher risk for diabetes even at much lower BMIs. So it varies considerably between people. That's the first thing. The second thing is that BMI is actually a very imprecise and crude measure to begin with. And what BMI is you simply take your weight in kilograms and you divide it by your height in metric system squared. That's what it is. And so it's easily confused. If you're a weightlifter, you'll have a very high BMI. It doesn't necessarily mean that you have a weight, you should be concerned about diabetes, for example. So there are much more accurate ways to measure body fat, and particularly central adiposity, which is what is actually dangerous for these health risks. But none of them are cheap enough to administer on a wide scale to millions of people yet. So we don't necessarily have the best metrics.
And the second part of that question is in terms of education.
Yes.
Once people have an understanding of where they maybe sit on that scale,
Yeah.
have you seen that education has an impact on changing behaviors?
Well, I don't think, I have not seen good evidence that any single thing by itself has had much of an impact. Only things that are combined with other things seem to have an impact in this space. And I think we can be much more clever about how we combine things. Also, just to give you a sense of what this actually means, I looked it up ahead of time in case someone asked. For a 5'9" man, which is the average height for a man in the United States, BMI of 25, which is the threshold of overweight, is 170 pounds, and a BMI of 30 is 200 pounds. Just to give you some perspective on what those numbers mean. Other questions? Yeah.
What's been the most successful pairing of solutions that you've seen to date?
Well, I think the most successful pairing is not a pairing, but whatever the word is for 14 things that you do at once. But these so-called whole of community interventions, where you go into a community, you understand what's important to that community, you understand the forces that are at work, the things that matter to people, and you try to find a way to have a light touch in what you change, to do things that will actually work, that aren't onerous for people, and that cover all the bases. So you do things in the schools, you do things with parents, you do things at the rec center and the community center, you do things with social media, and you do all of these things in a way that has a plan. That's what seems to work best, this whole of community intervention. And there are some really good examples of that, and there are also some examples where it didn't work. And what we're trying to understand is how to translate the ones that did work everywhere. It also tends to be a good level at which to intervene, because you're close enough to people that you can hear what they have to say. You can devise solutions that will actually work for them. And you can solve these coordination problems. It's much easier at a city level to get the Department of Transportation and the Department of Health to talk to each other than it is at the federal level, for example. But at the same time, at a community level, you're at a big enough level of scale, you can actually do things about zoning, about economies of scale in schools, and what the school board chooses to value and things like this. Yeah. Other questions? Yeah.
Can you speak at all to the economic stratifications between low-income obese people and high-income obese people?
Well, so originally, early in this epidemic, Obesity was much more prevalent in the poor, but that's not the case anymore. It affects every income bracket in the U.S. You can't have 2/3 of the people in the country overweight and have it not affecting pretty much every income bracket. That said, the solutions that work to try to address obesity and prevent obesity may turn out to be different in different income brackets. And there are interaction effects of what the implication of being obese is professionally or personally in different income brackets, and for men and for women, as I showed on that earlier slide. Yeah.
You've spoken a lot about the community impacts and the community ability to maybe impact obesity rates.
Yep.
What do you see the federal and state level policymakers and the impact they're able to make on community level initiatives to address this growing epidemic?
Well, so there are many examples of that. I think one thing that the federal level and the state level can do is to fund, to provide the resources, whoever asked about resources earlier, to actually do some of these things. And actually the CDC is doing that. They're doing things like putting community prevention to work is an initiative they have where they actually fund community prevention efforts in this area. The other thing that you can do at a higher policy level is to try to address the more systemic things, how our food system works, how taxation and pricing policy and advertising policy, those are the purview of the FTC and the FCC and the Department of Agriculture, and those are much easier to address in a more systemic way than they are in a local way. One more question. Yes, right here.
Going back to the causes instead of the solutions,
Yes.
if you have a society or a nation in which this is not yet a problem,
Yes.
are you in a position yet where you can say if these three things happen, you've got trouble?
Yes and no. There are some things we definitely know are harbingers of a changed future. And one of them is, frankly, that as countries become more wealthy, they start eating a lot more meat. They start eating a lot more processed food. They start eating more like Americans do. And that doesn't go well, usually. So there are some things that we're learning that apply to developing countries. Are we out of time?
I think we might stop here.
Okay.
Thank you all. Ross will be around if you still have questions that we didn't get to. And if you're going out to dinner after this, please make some good choices.
Thanks for coming.